Thank you for that. My name is Mutono Nyamai, and I work at the Center for Epidemiological Modeling and Analysis, which is at the University of Nairobi. I am going to talk to you about the elimination of transmission of onchocerciasis, particularly in Sub-Saharan Africa. Onchocerciasis is mainly transmitted through the black fly, and the main transmitter is the Onchocerca volvulus, which mainly develops in the human person, and it's transmitted by the black fly. And with it, you get a lot of transmission, where I'll talk about the cycle of it in a short while, but then increased intensity leads to infectious blindness, as you can see in the graphic below. There has been elimination strategies for this. One is mainly through the vector control, where they use aerial larviciding, and also through the mass drug administration of ivermectin. There's the target to eliminate onchocerciasis by 2030, and this work just mainly tries to understand what are the factors that countries need to put in place to be able to meet that target. I will start with introduction of the life cycle of the disease. As I said, the main host is the black fly, where here during the black fly, when it's taking a blood meal from the human being, it ingests the microfilaria, which are just the small worms, the stage 0 larva, which is produced by the adult worms in the human being. When the black fly ingests this microfilaria, it then stays in the black fly, and it grows to the stage 3 infectious stage of the larva, and this now migrates back to the human being when now the black fly takes another blood meal, and this now goes to the human being, specifically in the pelvic areas, and there it now grows into an adult worm. And when it copulates with a male and female copulate, they produce 1,000 to 2,000 microfilaria every day. And now the microfilaria find themselves to the skin, and the cycle continues. And when there's an increased intensity of the microfilaria, they swim through the bloodstream to the eye, and then they block the cornea, and that now leads to the infectious blindness. The disease is a second main cause of infectious blindness after trachoma, and the high burden of this disease is found mainly in Africa, with a few cases found in Yemen and in the Americas. Around 37 million people are infected by the disease, and 90 million people are at risk. The disease leads to excess mortality, mainly due to the blindness and increased intensity, and it's also associated with epilepsy. It's one of the neglected tropical diseases that is targeted for elimination. That's through interruption of transmission by 2030. There have been control and elimination programs which start all the way from 1974. The first control strategy was mainly using the vector control through aerial larviciding of the black fly breeding areas. And this ran from 1974, and it was mainly targeting the West African region, which had a really high intensity of onchocerciasis. In 1989, ivermectin was found to be effective towards the microfilaria, and it was commissioned to be used in the control strategy for onchocerciasis. And this saw that other countries which are endemic to the disease being introduced in the program. And in Africa, the program was under the African Program for Onchocerciasis Control, while in the Americas, this was the onchocerciasis elimination program for the Americas. These two programs were mainly using ivermectin as a mass drug administration, where it was given annually in the African region. In the American region, it was given biannually. The Africa Program for Onchocerciasis Control ended in 2015, but there has been another program, which is called the Expanded Special Project for the elimination of neglected tropical disease in Africa, which basically just brings together all the entities and tries to use one main program to try and control, eliminate the entities, specifically in the Sub-Saharan African region. Initially, the focus was on control, but we had a first proof of principle in 2009, where they realized that it was possible to eliminate onchocerciasis using ivermectin only. And this was seen in some foci in Mali and Senegal, where after 15 to 17 years of ivermectin, they were able to disease. It's now control to elimination, and there was a three-phased approach for the phase one was mainly treatment of at least 80% population, and this treatment placed 13 to 20 years, and this was mainly based on the endemicity of the areas that are really highly endemic, were taking a longer time for the treatment. And also this coincided with the adult lifespan of the worm, which is on average 10 to 14 years. Once countries had treated the population continuously, they were to now try and do evaluation studies where if the microfilaria in the population was less than 0.1% threshold, they'd now move to step 2, where they would collect blood samples from at least 2,000 children and skin snips, children below 10 years, and test the samples. And if a threshold of less than 0.1% at the 95% upper limit was reached, then that would mean that the foci had reached the elimination and they were to stop the mass drug administration and move to phase 3, where they would do a surveillance after 5 years and check if the elimination threshold has still been met. The elimination threshold contained serological and parasitological evaluations, where the epidemiological one I've talked about, but the second one was to test at least 6,000 blackheads and look for a threshold met of at least less than 0.05% at the upper 95% confidence interval. However, if a country had eliminated the black flies, they would then only do the epidemiological test, and if this was met, then they would move to the phase 3 and stop treatment and do surveillance for 5 years to see if they had indeed met the elimination threshold. There has been control and elimination of onchocerciasis for more than 30 years, and the program has elicited success in some areas, while some areas still struggle with eliminating the disease. There have also been 2 main mathematical models which have been used to predict the different elimination timelines. And the two main mathematical models give varying results specifically on the time that it should take to eliminate the disease and stop the mass drug administration in these different areas. This has complicated the decision-making by the affected countries and also the funders, where they are conflicted as to which model they need to follow with regards to stopping the treatment and moving to the 3rd phase. With this, we've also seen that there are gaps in the key drivers of elimination success, and this varies across the different settings and also with the different interventions, where some areas use the ivermectin treatment only, while others use both the ivermectin and the vector control methods. And this now led to the main aim of this work, where we went what were the times required for elimination and what key drivers to ensure that the success of elimination had been achieved. We then went ahead to review studies that were published at least after 10 years of ivermectin treatment or that had reported elimination. We were able to get 63 studies, which were included in the systematic review, and we further excluded 19 studies in the meta-analysis, as these studies did not have baseline endemicity, and they were surveillance studies that had been conducted after the treatment process had been halted. We collected data mainly looking at the microfilaria prevalence of the different foci and also where the foci was located in the African region. And with this, we categorize it either as West, Central, and East Africa. We also looked at whether the different foci had done any vector control and the duration of vector control that they had taken, and the ecological feature of these areas, if it was either savanna, forest, or Africa mosaic, and also the proportion of population that was continuously not paying treatment, and the proportion also of population that had achieved at least 8 years of the treatment, 80% of the treatment, and how long it had. And we also looked at categorizing it as hypoendemic, that areas with low intensity, all the way to holoendemic, which are areas that had a really intensity. We also collected information on endemicity of other neglected tropical diseases in these areas. The main outcome for this work was the microfilaria prevalence of these areas. And with this, we used it to categorize the areas into 3, where one was it had interrupted transmission. And with this, it had used the biological evaluations I had earlier mentioned. The ones that had the transmission to elimination, that means that they had a less than 1% microfilaria prevalence, or whether they were having ongoing transmission. That is, if they had of 1%, with the to regression analysis and for being either a way to just and closer or further. With this, we were able to have 231 foci, where more than 60% of them were still having ongoing transmission, while almost 30% had achieved elimination of transmission. And these foci that had achieved the elimination were mainly seen in the East Africa, which are having 7 out of the 15 foci, and others were in East Africa, such as the one in Sudan and in Ethiopia, while others were in West Africa. The graph that you can see just shows you the areas where we were able to get studies from, and it was interesting to see that the ones that are shaded in dark gray did not have any published studies on the evaluation process, in as much as they had been having the ivermectin treatment programs for more than 10 years. We, having categorized the studies into 3, whether having achieved elimination, being close to elimination, or ongoing transmission, we went and grouped whether it was using vector control with ivermectin or just ivermectin alone. And you are able to see from this graph that when you look at the first column, for example, the part G, we can see that the studies that were using both vector control and ivermectin had a really high intensity during the baseline period. And you can see that with the microfilaria prevalent areas, the darker the shade, high intensity that started with before the intervention programs. We are able, when you look at the graph G, that this area started from being a high intensity area. That means it was hyperendemic. And for it to be able to meet the elimination of transmission, it took more than 20 years to do that. And that also included using vector control. The areas that were without vector control, we can see that they started from a relatively lower endemicity level, and they took a relatively shorter period to eliminate onchocerciasis. When you look at the graph G, H, and I, and also J, you can see that they somewhat have the same trajectory, but some have already met the success of eliminating the disease, while others are still close to elimination, but still having the mass drug administration program running. We then wanted to go a step further and understand what are the factors the countries that were able to eliminate transmission use that these other areas would benefit from using and also work towards eliminating the disease. With this graph, you can see that we have divided it into three. The upper bit, which is the CMFL, just stands for the community microfilariae. And with this, they mean the skin snips that are collected from the population, and they count how many microfilaria are seen from that skin snip. And with that, they are able to depict the microfilaria load in the community. The second row shows the microfilaria prevalence, where the higher the intensity, the more the countries also work with vector control methods. While the last one just shows the nodule prevalence. And the nodules are usually seen on the skin, and they usually do nodulectomy, where they try and remove the nodules from the skin and just try and do a prevalence of, from the people that they are studying, how many have been seen to have nodules in their bodies. The other bit was doing the meta-regression results, where we tried to understand what are the factors that were associated with countries being closer to elimination. And we saw that the years of continuous therapeutic treatment, where we had mentioned that the continuous therapeutic treatment needs to be at least targeting 80% of the eligible population, and areas that had the continuous therapeutic treatment for 10 years or more were able to achieve elimination compared to the ones that had less than 10 years of the continuous treatment. We also saw that the number of years of ivermectin treatment, where at least 14 years was required for a foresight to be closer to eliminating the disease. And this is mainly coinciding the life cycle of the adult worm, which takes at least 10 to 14 years. And once the countries were past the 14 years threshold, we started seeing that they're eliminating the disease. The other one was the region where the area was located, where we saw, compared to the Central Africa region, the West Africa region and the East Africa region was closer to eliminating the disease. And this is mainly depicted by two things. One is that the mass drug administration programs in Central Africa have mainly been affected by the civil war that is seen in that region. And second, these areas are also co-endemic with Loa, which if someone has a really high intensity of Loa and you give them ivermectin, they always fall into a severe adverse, they always have severe adverse effects, and even sometimes it leads to mortality. So the mass drug administration programs here have taken a bit of toll, where they use the test and treat strategy. They first test the person to look at the intensity of the Loa, and if the intensity is lower than the threshold, then they give this person ivermectin. If it's higher than the threshold, then they do not treat this person with ivermectin. The factors that were associated with an area being harder to eliminate the disease was one where they were having more than 5% systematic non-adherence. And this was just the population that over every year were not adhering to the treatment. So they ended up still having a high microfilaria load, and that's continued with the whole life cycle of the disease. The second one was the forest ecological areas, where compared to savanna areas, forest areas were harder to eliminate. And this coincides with the black fly species that is seen in these areas. With the savanna areas, the black fly species needs the black fly species needs the crab host to be able to ease with its development. And so once the crab is eliminated in savanna region, then you automatically eliminate the black fly vectors. However, in the forest ecological areas, the black fly vector doesn't require the crab as a host. And so there is also an increased risk of the black fly vector moving to maturity compared to the savanna area. The other factor was the baseline endemicity, where areas that had a really high intensity before the treatment process began were harder to eliminate. And we've also seen in the previous graph where I showed that some areas have taken over 20 years to eliminate the disease. And this was also mainly tied around the baseline endemicity, where the areas that had a relatively lower endemicity were taking a lower time period to eliminate the disease. The recommendation from this work is that there needs to be longer investment, specifically in the treatment process, where the programs need to focus on continuous treatment of at least 80% of the eligible population, and also work towards reducing the non-adherence levels in these areas. There should also be priority given to the forest areas and the hyper-endemic areas, which have a high intensity. And in these forest areas, they can also try and not only use ivermectin, but also combine it with the vector control methods. And consideration should be given for conflict areas and also areas that are co-endemic with other neglected tropical diseases, specifically areas co-endemic with Loa. I would like to acknowledge the team that has worked around this work. That's the team from SEMA, the team from Imperial College London, the University of Oxford, and Erasmus University Medical Center, where all these people are part of the Neglected Tropical Diseases Modeling Consortium that gets questions from WHO, which help them to understand the policy implications on the neglected tropical diseases. This work is also funded by the Bill and the Gates Foundation.